Can I begin now?
Yes.
All right. Hello, everyone. Good afternoon from Kuala Lumpur, Malaysia. A happy new year to all our participants and welcome to this ISSUP webinar. My name is Datuk Zainuddin and I shall be your moderator. This webinar is organized by ISSUP Malaysia and hosted by ISSUP Global. The topic for discussion for this webinar is Mobilizing Community Resources in Preventive Measures, Issues, Challenges, and the Way Forward. Now, how does one mobilize communities to prevent the onset of substance use or to limit the development of problems associated with the use of psychoactive substances? The mastering of community resources has been touted as one of the most effective means of achieving this. How is this done? We will need to listen to the thoughts, ideas, and comments from our esteemed speakers. We have three speakers coming from three different continents. We have Asia, we have Africa, and we have Europe. While they may come from different parts of the world, they have one thing in common. They are all proven experts in the field of the drug demand reduction. Now, let's just take a pause here and allow me to very quickly go through some of our ground rules. We have an allocation of 60 minutes for this webinar. Each speaker will be given 15 minutes. That adds up to 45 minutes, leaving us just between 15 to 10 minutes for question and answers, which will take place after all the three speakers have had their say. Those of you who would like to ask questions, kindly use the chat box or the chat column. Do include your name as well as your country. Now, before I go further, I am requested to make the following disclaimer. Please note that this webinar is provided for informational purpose only and does not constitute medical or treatment advice. The views presented here are those of the speakers and not necessarily those of ISSUP. Now, with that disclaimer, let me now turn to our speakers. Our first speaker is Cindy Bidding. Aside from being the president of ISSUP Malaysia, she is also the founding president of OCTA, which stands for Organization for Addiction, Prevention, and Rehabilitation. Cindy is a global trainer in treatment. She has been and continues to be actively involved in DDR-related activities and programs covering both prevention and treatment. Cindy, you have the floor.
Can you see my screen?
Yes.
Dato. Thank you very much. Thank you, Dato, for the introduction. A very good morning, good afternoon, and good evening to all participants out there who are joining us for this webinar. So I'm going to share a little bit on mobilizing community resources in preventive measures, the issues, the challenges, and the way forward. Now, I will be speaking mainly from the context of Malaysia and also the Asian region in general. So we know that the drug problem is a major concern in our communities. And our communities experience a wide range of negative consequences associated with drug issues. Therefore, because the problems come from the community, we give back the responsibility to the communities to help address these drug use problems. And also because within the community itself, there are many resources that the community can use to help address the problem. So we look at the community resources. So when we talk about community resources here, we are referring to community groups and organizations. They may consist of religious group, groups from school, women's group, youth groups, they are all powerful groups. The local community leaders, the local government agencies that would include the health workers, social workers, teachers, and counselors, and so on. And also the relevant NGOs, those NGOs that work alongside communities to help implement preventive intervention in the community. Some of the other community resources would include local businesses and local business organizations to support prevention efforts through partnership and donation. Now, many of our local business and business organizations have their own funding allocated for corporate social responsibility or CSR. And often these companies or business organizations partner with agencies or NGOs to implement such program in prevention. And sometimes they don't do that, but they prefer to give donations. So these are some resources. The social media and other forms of digital communication also play a part to reach out to communities and engage communities. We have so many different types of social media network, and communities nowadays, even those in the rural areas, have access to internet connectivity. Many of them have smartphone, and the largest social media network that is being very popular also among our communities include Facebook, Instagram, Twitter, YouTube, and TikTok. I know many people like to watch some TikTok and some YouTube videos, and sometimes social media really play a part in helping to engage communities. Local media outlets, they may be in the form of newspaper or even online papers, also can be used to disseminate information and educate the public about prevention. So while we have resources in the community that members of the community can use, on the other hand, we also have issues and challenges in implementing these prevention measures. One of the major issue and challenge here really is the lack of awareness and understanding of the term prevention and prevention measures. And of course, understanding the importance of preventive measures among community members. They can talk about prevention, but it may not necessarily be prevention. Secondly, the limited resources sometimes in some communities or in many communities, and the funding, the resources refer to the funding mostly to help preventive measures in the community. And of course, the other thing is, the other issue and challenge is the limited capacity and expertise among community leaders and organizations to implement preventive measures. So when you don't have the capacity or the expertise, it becomes really a challenge. Then we look at the inconsistency of monitoring and evaluation. So when prevention programs are being implemented, yes, they are, but monitoring and evaluating or assessing the impact, the effectiveness of the program is not being consistent. When that happens, we don't see, the members of the community do not see the impact on the community, and that leads to them being less enthusiastic, and prevention becomes not their priority. Also, limited research on prevention work. That is because, again, not many prevention programs are being conducted or carried out. So when there's not much research, there's also not much impact that is being measured. Then the issue of stigma. So stigma is always the issue, because here in my part of the world, many programs are being targeted, many prevention programs are being targeted at those who are already affected by substance use. And they stigmatize the people who are affected, when in fact prevention program need really to start where no drug use is prevalent. And then the lack of interagency collaboration and coordination. Sometimes we see just one agency trying to work on its own. So there has to be more interaction between the multiple agencies in order to carry out these problems. The intervention. So how do we go about looking at the way forward? And of course, we need to develop the resources, strategies, and educational strategies so that people understand what prevention is. Our education strategies and our communication about what prevention is about and what preventive measures is about, so that people know better and they understand better. And of course, providing financial and other resources to support community-based prevention measures. I think that one of the thing that we said is the challenge is the funding resources. So we need the government agencies or business organization, as we mentioned just now, really need to provide some financial support to support community-based preventive measures. And of course, to build the capacity and expertise among community members and organizations to lead and coordinate preventive measures. It is necessary to have evidence-based prevention training in order to build the capacity of people to lead these preventive measures. And of course, the advocacy, we really need to consistently and persistently advocate for drug policy that is active, that is workable, particularly with respect to incorporating a drug education program into the school curriculum, like some of our European countries, where their prevention program actually are incorporated into the school curriculum. And of course, to create a supportive policy, we need to advocate to have a supportive policy and regulatory environment that enables and encourage community-based prevention measures. And then, of course, my favorite is really the school-based prevention program. It is necessary to have the school-based prevention program both at the primary and secondary school level, where the promotion of healthy lifestyle and well-being is being emphasized, and it should include activities about teaching life skills and social skills, problem solving and decision making skills, so that the young people or the children learn to be resilient after they learn these skills. And in implementing prevention program, families must be involved. People in the workplace must be involved. And funds that are allocated for prevention program need to be distributed accordingly, so that people have the funds to work with to implement prevention program in school, in the workplace, and in the communities, well, through either the local council or the workplaces. Then, so school-based
You have 3 more
again.
minutes.
Yes, don't worry, I'm about to finish right now. School-based prevention program is really a must, because schools are the best place to begin. The children and the students spend a lot of time in school, so young people need to learn the skills, the essential skill essential life skill to build confidence and stay resilient. So thank you very much. That's all, Dato.
Thank you, Cindy. Congratulations for keeping to the time. Your time management is excellent.
Yeah.
Well, I will not, given our severe time constraints, I will not even begin to summarize the excellent points raised by Cindy. Suffice to say that she did something really excellent and worthwhile thinking. With that, may I now move on to our next speaker. Now, our second speaker is Professor Mikhail Mijovsky, Professor of Clinical Psychology to the Charles University in Prague, Czech Republic. Professor Mikhail is actively engaged both locally and internationally in drug demand reduction related studies and programs. Professor, you have the floor.
Thank you very much, and good morning or afternoon from Prague, wherever you are. And thank you for this invitation. And I would like to speak about university perspective, what will be slightly different from Cindy's presentation, but I think that there is important to emphasize that cooperation and contribution by universities to the local level, to the regional level is very important, and I would like to say how. So the main issue of today's work, what we are doing on universities, is developing curricula and competency models, and that's the beginning of my presentation, and I will end also with this issue at the end of my presentation. But at the beginning, I should to say that what is really sad, but that's a fact, is that we have a still problem how to recognize prevention professionals and how to train prevention professionals. Despite the fact that we have many different curricula, international curricula, we have very different and nice models already implemented and successfully implemented, but still it's not something what is shared by all countries, and something where it's not too easy define who is enough trained and what kind of knowledge, skills, and competencies should to be delivered and accepted by people who are, by trainees in our programs. At the beginning, we had to start with mapping of universities, and we needed to know how many universities are operating these programs and providing this special kind of education and training to students. So this work has started almost 10 years ago, and at the beginning we mapped European universities, and in this paper we summarized the results, and you can find it on my ResearchGate profile, and I will give you my link at the end of my presentation. The second step was mapping US universities and Canada. The third step was mapping of African programs with our African colleagues, and it was already published. And now we are finishing New Zealand and Australia, and we'll move to Asia. And it's step-by-step process where we try to identify how many universities and what kind of programs they are operating. What is expectable? We found many different models and very interesting models already implemented on universities. And as you can see, we can recognize something what is really simple and delivered by almost all universities, and it's specialized trainings and education programs at the level of particular courses. Some universities are offering and are operating summer or winter schools specializing on addictions or specifically on prevention. Some universities have a fully comprehensive academic degree programs, bachelor, master, PhD programs, specifically focused on addictions or prevention. And we can also find some lifelong education and training programs operated by universities. As a secondary analysis, we tried to analyze these programs and created this very simple typology. And especially we were focused on prevention and try to identify how many universities and how many programs we have with a special component focus on prevention. This was already published 1 year ago, and it's available in full text on my ResearchGate profile too. So it's not so long time when we have established our platform, academic platform for universities, called International Consortium of Universities on Drug Demand Reduction. And this consortium today have more than 300 members. And we are trying to invite more academic institutions and colleagues from different parts of the world. And now we have almost 50 member countries represented by these academic institutions. So I will start with a very brief reflection of what we did within the last 3 years within COVID times, and we conducted some needs assessments in this area. What was clear and important to us was relatively sad and frustrating finds related to the fact that only 13% of universities are planning or conducting specific subjects or courses focused on prevention areas. It means that majority of our member universities are focused on treatment or harm reduction, usually on treatment, and that's probably something what we can say or what we can call as a weak. And at the same time, prevention area is almost missing in majority of university programs. So it is very important fact and finding from this first analysis. We can also say that our university programs usually have very narrow profile. As I said, usually focus on treatment and some programs also on harm reduction. But it's something where we can find weakness of this program, and we can say that it's something where we are losing attractiveness in the eyes of students. And despite the fact that we have a huge diversity on a real labor market, and we have on the other hand, we have a weak institutional infrastructure, I mean very little number of prevention providers, still that's something what is calling for making the profile of this program a little bit more broader. At the same time, we have a missing classic career pathway, especially in prevention, and lack of collaboration with real service providers in local communities. I mean, a well-established cooperation between university programs and local providers, specifically providers of prevention measures. We have a very simple analysis how important it is, and these university programs and trainings without more intensive collaboration with local bodies, with local providers, it's something what is not good, what is not effective, and where we have a very clear need, where we need to improve our work. At the same time, in many countries we have almost missing real infrastructure and real prevention providers supported by governments and local governments, and where we can say and where we can speak about a real stable network of service providers at the local level. The second issue where we was focused on are curricula. As I said, we have some national, some international curricula. We are trying to support the real implementation process. And again, it's about mixing this curricula and creating more comprehensive university study programs. So we have started with UPC, that you are probably familiar, all of you, with UPC, Universal Prevention Curricula. And we have started how we can implement it into the real university context. I mean, fully academic degree programs or courses with using this curricula, not only a lifelong education training, what is really a common product delivered by universities. I can provide 3 very simple examples what we did in Europe. Because of a shorter version, more comprehensive and compressed version of a universal prevention curricula. The first was adaptation project. The second was online training, and the third was the real university prevention curricula adaptation into the full comprehensive program. This is example from my team from Prague, where we used the UPC and implemented UPC into our bachelor, master, and PhD program, what we are operating on Charles University here in Prague. So recommendations for discussion, not only for ISSUP DDR members, and I think that it's very good reason why to speak about it today. I think that what we can improve is learn better from successful models. For instance, we have very nice PhD program already implemented and successfully operated in Zagreb. Another example of master programs integrated prevention into the curricula is in Spain on Balearic Islands, and in Georgia in Tbilisi. Both case studies are really nice, both are published and available, and I think that these two case studies are representing the best practice in terms of mixing treatment and prevention together in one comprehensive university curricula. We have also specific implementation guide and implementation support for universities and university teams, how to start and how to develop and how to establish and successfully run university program. Through the COVID time, we reflected that in many ways we have a problem how to make our cooperation more intensive, and because of economical aspects and many other obstacles, including COVID, we need to develop more online products and be well prepared and better prepared for the future in this matter. So this is our work, what we did here with a couple of universities and created small group. At the beginning was adaptation of UPC, the full UPC, into the more compressed version. It's 40 hours version called European Prevention Curriculum. It's public domain. It means that this curriculum is available like other UPC versions. And this is small piece of contribution from Europe into this international work. And we have developed INEP online course, what is very small and simple product, and in reality it means online product for 40 hours version. That's a basic. We have also shorter version for 8 hours, but it's just teaser for this fully comprehensive program. So, and we have developed it as an online course in these two mutations. And what we did was invitation to our colleagues, and the first step was developing Spanish version, what we did with University of Balearic Islands. And the second step was Portuguese version, developed with Open University of Lisbon. And now we are finishing also Ukraine version, what we have created with University of Kiev, together with Peru. It was trilateral project. So it means that at this moment we have 4 language mutations, and we are providing this online version training also together with ISSUP, and we have a ISSUP Plus training, what practically means mix of online course together with real tutor and more comprehensive program, mixing the online version and real practicing and training competencies and skills in this program. We have also a very special branch focus on online mobility program, and we are trying to develop this online mobility program together with universities inside of Europe and outside of Europe. And this is our first generation of this system, because we have always a problem with money, and one way how we can reduce the budget and make it more real is online mobility. Professor Susan Henriquez from Lisbon created very simple pilot project for first group of universities. And at this moment, we have in our data bank 23 courses, and we are offering these courses each other. And in 23 this year, we will test it. And if this pilot study will be successful, we have a plan to make it more broader and spread it into the another regions and invite more universities to share this online mobility program. So my last point, and I will end with this contribution, is quality standards and competency models. And quality standards now is big issue for international community. And the first step, what we did and what we do now is creating a competency model for university programs focused on treatment. So part of this work is also quality of workforce, and that's the big issue for us, how to formulate and how to create and how to test and implement different quality assurance systems for university. And that's also very challenging issue for our broader community. I mean, specifically ISSUP and ICQ. Probably all of you are familiar with our new international agency called ICQ, what is focused on quality and quality standards, and what was launched last year in Abu Dhabi on ISSUP conference. And this is very simple example from Prague, because we have started with this issue more than 10 years ago and created very simple 4-level models of qualifications for prevention professionals and tested in our country on 110 volunteers, and it was successfully tested and already published, as you can see, and you can find this paper also on my ResearchGate profile. So I should proceed to the final slide. And as I said, our main focus now is on developing competency models. And we realized that developing competency model is something very broad and very difficult. And we have decided that the first step should to be creating competency model for treatment, because we have a more experiences and longer history of these programs on universities. And we created international small expert group together with representative of ISSUP, GCCC, NIDAC, and other international partners. And within 22 last year, we created first competency model, and it's under discussion now, and we will publish it and make it available also to all of you. And that's the first step. And second step will be creating another international group or task force and develop something very similar. I mean, competency model, but specifically focus on prevention. I mean, to formulate what kind of knowledge, skills, and competencies are necessary for prevention professionals trained in our university programs and also outside of academic sphere. I mean, specifically by NGOs and other training agencies in communities. So we also try to improve our work with champions. And Champions Forum is something very simple. We have this name for group of universities operating their programs for longer than 10 years. And champions is because they survived, because it's not so easy to operate these programs. And if they survived more than 10 years, we call them champions and try to learn how they did it, how they struggled, they fight on labor market, and how they are working with students and inviting students and having enough students for operating this program. So now we have a very simple small pilot study on 6 champion programs and trying to learn what they did and how step by step in terms of establishing and operating and surviving these programs in academic community and survive all pressures from outside. So that's end of my presentation, and I will be very happy to respond to your questions. And you can find all of my papers, what I was cited on my ResearchGate profile. If you are using ResearchGate, you can find full text on this platform. Thank you very much.
Thank you, Professor. I can only say that you have given us a most interesting and comprehensive analysis, and a very interesting and comprehensive analysis, and supported by so many facts. I find it really intriguing. Thank you very much. And now let's move on to our third and final speaker. He is Dr. Richard M. Gakunju from Kenya. He is credentialed Global Master Trainer for both prevention and treatment. Dr. Richard has written several research papers related to the adverse consequences of a drug-taking behavior. He has held numerous positions consistent with his specialization and was a former Chair Emeritus of the Kenya Certification Council. Dr. Richard, let's hear your presentation.
Thank you very much, all the speakers who have been there, and thank you, Professor Mayovsky and Cindy, and also our chair, Dr. Dato. Mine is the privilege to be the last speaker. A lot has already been spoken on in terms of how you mobilize community programs in terms of prevention, and I'll be able to just be able to do that in a little while. So let me first take this. So you are able to see my screen, I pray, Dr. Dato?
Yes.
Good. As I was said earlier, I am a global master trainer in prevention, and I have been a former chair of the Kenya Certification Council. Worked in many parts of the world, including Africa, Asia, and even Europe and the Americas. And so I bring some perspectives from the continent of Africa, having spoken to a number of my colleagues in terms of what is happening in terms of the topic that we are handling today, mobilizing community resources in prevention measures, issues and challenges, and way forward. I like one thing that was mentioned by Professor Mayovsky, that we need attractiveness in the eyes of the students. And here today, I'll say that we need this attractiveness in the eyes of the community. I am trying to move my slide, it's not moving. Oh, good. So as we look at the community, it may not be easy to find prevention services. The community is composed of many elements, and some of them have been mentioned by my prior speakers. Prevention work is often housed in a set of locales, often mask other types of interventions. And we have seen like schools, social services, family support organizations, religious institutions, hospitals, workplaces, and enforcement facilities. In my setting in Kenya and in Africa, we have many different types of settings in terms of community. So it is important to understand what we mean by community in all these settings. But as I said earlier, prevention is found in one way or the other in this. And what has been spoken about earlier in terms of, for example, the approach from academic perspective by Professor Mayovsky, and also from traditional maybe approaches like Cindy has mentioned. Now we need now to merge this with what is happening in the world. The services that we are talking about include educational counseling, family support, youth activities, and others that have been mentioned. It also includes workplace, human services, and media campaigns. And Cindy has really spoken about media and the print media and even the social media. Indeed, prevention professionals work in all of these settings to deliver prevention services to the community. The main goal being in any community that we provide positive support to prevent problem behavior like substance use, and must include of engagement of the community itself and national prevention health prevention policies, eliminating disparities in availability, access, and funding of prevention services. And this is very important because in many of our settings, we find that availability, access, and funding of prevention services is downplayed in terms of the priorities that are within our context it may be because of other priorities that the country or the nation or the continent is looking at. The other thing that we also must consider is improving the quality of services and prevention outcomes of the communities. Some of the presentations that have been done have alluded to this in terms of monitoring and evaluation, and also looking at the evidence-based interventions worldwide, and also localized interventions. So what are the global considerations in prevention issues? Well, the global recession currently taking place worldwide, and you have seen even in the US, they have reached their maximum borrowing point, and they're in a stage where they are trying to do like many other countries are doing, trying to look at what is priority for them. And this is a major concern for many nations, and ours are included. The ballooning public debt and weakening of national currencies is another issue that is a consideration. Rising borrowing costs and poor employment outlook for youth. We have many of our youth who are the targets of prevention, who are either in transition between school and university, or they are between university and work, and they are at great risk. The risk factors are really manifested in this particular season. COVID-19 pandemic has really taught us many things, including what we are doing now. We can be able to go online and train ourselves and read together. The Ukraine war has been mentioned, disruption of the global supply chains. Climate change, which has not been considered in aspects of prevention. And I am glad that in our country, we have a community that is looking at climate change in terms of its relationship with the prevention and treatment of persons using psychoactive substances. We know that the climate change has affected the government budgets. It has affected the crop agriculture. We have seen homes being destroyed in many countries in Asia, Africa, the Americas, globally, even in Europe. Prevention, therefore, is very important. But remember, prevention is also a relatively new concept. Having in the last 20, 25 years is when the issue or the context or the curricula of prevention have been developed. And being a relatively new concept, there may be some sort of barrier to its acceptance. The other thing is that the evidence-based programs that have been rolled out, many of which have been developed in either the US and in Europe, requiring involvement of the developer and charging quite a bit of money. And we need to have a look at this in terms of appropriateness in our setting, whether the EBPs, which are not only expensive, but maybe sometimes not contextualized, need that contextualization. And I like, again, what the Professor Majewski is doing in terms of studies. We have an opportunity to carry out our own studies and see what works best for us, and indeed can be considered as evidence-based. So what is the bottom line of these global considerations? There is poor buy-in of evidence-based programs in view of competing priorities, meaning that countries and nations have other bigger priorities than getting an expensive evidence-based program developed elsewhere and trying to implement it. But this also can be used as an opportunity. So let's look at the regional considerations in terms of barriers and challenges. Well, there is we have alluded to the problem of stigma, which constitutes some form of resistance to cultural diversities. Some cultures do not even recognize addiction as a major problem, or they consider it as one of those issues that should not be discussed openly. So there is that resistance to cultural diversities. Lack of support from community leaders, including political goodwill among leaders. There are countries that do not have even programs that touch on prevention within our setting, and this could be one of the other challenges. There is, of course, globally now, there is less disposable income, which we call discretionary income, meaning that the resources that we would draw from these disposable incomes, especially when we are running programs that are people-based and they need collaboration, what we call public-private partnerships, they are hindered because of this problem. We know that the industry itself, especially the alcohol and tobacco industries, are financing countering persuasive messages, heavy budgets from these institutions. And when you are mobilizing communities, we need to take that in consideration too. National bodies or focal points targeting prevention are absent in many countries. And where they exist, sometimes they are counterproductive in terms of addressing issues to do with prevention. And when I talk about a focal point, it doesn't have to be the government. It could be a big NGO, or it could be ISSUP itself. And we need to continue now focusing on a system where we can mandate such focal points to work in the countries that they are able to in terms of fundraising. NGOs and many organizations largely fundraise on their own, and again, funds have been mentioned earlier. Programs are wrapped up as soon as funding ceases. There are some programs that have been running in some countries in the African region, and once funds run out, that's it, and the programs fall up. So what are we going to sustain this? So we have opportunities in the community. One is that prevention trainings now are largely available online, free of charge, and where they are being charged, they are reasonably charged, and many professionals can get into prevention, into the prevention science to understand the dynamics of prevention and be engaged. We have also many more professionals willing to get in prevention programming. We have many people from different backgrounds, teachers, nurses, psychologists, sociologists, people who are in recovery. They're willing to get into prevention, and these programs will be able to empower them. So we'll be harnessing this community resource to be able to address prevention at the level where it really matters, at the community level. Integrated approaches of funding by pooling resources from other platforms like youth work, gender-based and HIV/AIDS programs. This means that we can drop funds from other programs or ride on those programs to be able to fund the community-based programs. So for sponsored life skills programs like by the UNODC and other bodies have really helped. So what are some of the other initiatives that we can take? One is that we are continually having an increased number of trained prevention practitioners, counselors, therapists, and other behavioral health practitioners. And I want to emphasize that in our setting, we really need these people at the middle level cadre. Middle level means that they are going to either tertiary institutions or middle level colleges, and they are able to get this knowledge. Or they are organizing groupings which are able to access the online trainings. The university approach is good, but in our setting, we think that we need more of the middle level cadre, and those are the people who are hands-on on the ground. And those are the people that we are targeting. Community listening sessions and trainings on topics of interest to the community. In our country, we call them barazas, where we get people together and we are able to listen in. Because many times we are developing programs that do not address the issues that the people want addressed. We are addressing what we as the researchers, we as the practitioners want to see, but we are not listening. So community must be listened to. We also need to look at the linkages of community members and other resources, especially through social media platforms and the other platforms available. Again, we also need to look at diversification of data collection by engaging non-traditional sources within communities. And for example, in our country, we are registering all farmers. Farmers are being registered whether you are on 1 acre or 10 acres. This can be used to collect data that will help prevention programming within communities. Training key socialization agents, apart from teachers and the professionals themselves. We could loop in community leaders like religious and community leaders, CBOs, coalition leaders and members, and of course, members of the community who are making efforts to reach youth and people with substance use disorders or lived experience. We can loop them in also and empower them, because it doesn't really need a lot of financing. It just needs that buy-in. And I got this as one of the quotes that you may want to carry with you. I'll not read through it. It is enhancing cultural competencies from CDC. It means the integration and transformation of knowledge, and so on and so forth. You can read that for the sake of time. Lastly, recommendations on building a community level prevention. We must provide opportunities for community conversations, and we have many platforms that we can do that. Community welfare groups. There are welfare groups, they may be neighborhood groups, or they may be women groups, or even chat groups within a WhatsApp group. There are many chat groups being formed, and we can use this as a way of enhancing the community conversations on prevention. We could also foster relationships with community allies and trusted members of the community, like the service providers who often come into the community and are involved in the security work. And also ask the community about their own needs and concerns and work with them to identify solutions. Because often, and I love research, but often what happens is that we can tailor even a questionnaire for our own needs instead of the needs of the concerns of the community. We need to engage the community to be able to be the ones generating that type of questionnaire. Follow through on any promises made to the community and keep them informed on progress. By doing this, you have the buy-in and you will be able to use their resources without even looking for others. So most importantly, of course, is bringing everyone to the table to maximize the effort, avoid duplication, where people are doing the same thing but in different ways, and monitor community services and their impact on substance use. Thank you very much all for listening, and I'll be happy to take your questions. Thank you.
Thank you very much, Dr. Richard. That was a most excellent presentation. Again, thank you. I do not see any questions yet on the chat box or on the chat column.
Can you look in the questions section? Because I think there's some that have maybe arrived in, if you open the questions.
Yeah, I have seen the questions, but I think mainly are comments, and there are a few which I have answered privately to them.
Oh, I see. Okay, but I have got a problem here. I do not see anything written or typed on my chat box. Anyway, Cindy, since you can see the questions, are there any questions other than just comments? Any of our esteemed speakers?
Yes, but I think I have also answered mostly are comments. Good comments, like all prevention program requires social science skill in community, organization, mobilization, and leadership, which should be the main subject in a training. Yeah. There are a lot of comments.
I found one question that I don't think has been answered.
Can we hear that, Olivia?
Sure. One of the problems of prevention is that there is little money in it, as opposed to treatment, where a lot of money is spent for the services of treatment professionals. How do you deal with this problem in your countries?
It's not directed to any one speaker, then we can open it to all the 3 speakers then. Anyone would like to come up first?
Maybe I can start.
Yes, Prof.
Yeah. Thank you. 2 examples, because it's every day dealing and struggling with this issue, and of course the budget is always not enough and not adequate. Okay. The first way how we deal with it in terms of training is that as I described and spoke about INEP training, Introduction to Evidence-Based Prevention, what we have developed. This is training what we are providing for free, and it means that it's open for other universities in Czech Republic and in other language mutations, also for outside universities outside of Czech Republic and outside of Europe. We are providing this training for free. It's online. It means that it's very limited, and INEP Plus is much more comprehensive and better program together with a real trainer. But for the university context, for students, online course is not so bad. And it's beginning, and it's something where students can meet the prevention issue. And if it's for free, it means that there is no reason and there is no any other obstacle on the side of other universities to use it. And at the same time, Charles University is guaranteed 3 ECT credits into the international system. It means that if students will finish the training, they will receive 3 ECT credits after the test. And any kind of university can accept it as a part of their curriculum. It means that it's for free and they don't need money. I mean, students or universities, they don't need money for achieving this training. That's one example. And second example, what we are doing is national supportive system for prevention providers. And I contracted 4 other companies, governmental companies in Czech Republic, and together with Charles University, we have developed and we are operating the national system for service providers. It means that they have a national catalog, they have a national data bank of prevention programs, they have a support for training, they have a point for sharing information and exchange of experiences, and we are operating the system for free. It means that we are trying to support our colleagues in the field for providing more programs, more evaluations and trainings, and we are doing this as a consortium of 5 organizations of 5 bodies, including Charles University, and we are providing this service for free for service providers. That's second example what we are doing, and of course it's money consuming, time consuming, energy consuming, and I spent 23 years on this hobby because my main work is treatment and I'm a psychotherapist and I have a responsibility for entire clinic. But this is my hobby. Prevention is my lifelong hobby, and this is what I am doing with my colleague for the field of prevention in my country.
Thank you, Prof. Any comments from either Dr. Richard or Cindy?
I think one of the things that we've been doing in our setting is to use the available running programs to ride on to run with, so that you are not incurring or looking for resources elsewhere. We have various organizations in our country that are doing a good job in terms of riding on existing programs, either existing treatment programs and turning them into prevention programs. For example, we have an association called APRAC that looks at the Association of Prevention and Treatment Professionals and the rehab owners. And we have also ISSUP Kenya, which also runs such programs. And we have also the National Focal Point, which is NACADA, which rolls out these programs in various settings, including workplaces and schools. We know a lot more needs to be done in terms of allocation of funds, in terms of using the capacity that we have. But I guess, as I said, because prevention has been riding on treatment, which has been the longest lasting, like Professor Majewski says, you know, we have all been in treatment and now we have come to prevention. I think we need now to begin looking at which other resources. The beauty is that the Kenyan curriculum, for example, has included elements of prevention in nearly all curriculums from primary school through to high school and actually going up to university. And we are hoping that going forward, this will be something that we're going to put.
Sorry, Richard, we are running out of time. Sorry, Richard, we are running out of time. Can I have one last comment, short comment from Cindy before we conclude this webinar?
No, there is a question actually here. Are there any school training online? There's a question from a participant.
Are there any schools online?
Training. Are there any school training online? For me, I do not know any in Malaysia, But yes, the INEP Plus is going to be conducted by ISSUP Malaysia next month, early next month. We have put out flyers on our ISSUP Malaysia webpage, Facebook, and also on Opta's webpage and Facebook.
Yeah,
That's all
and
from
maybe
Dato'.
I should do.
If I'm not
I should
mistaken,
do add.
most online trainings are done at a national or local level. It's not so much regional or global. Am I right? Yeah. Okay. We are well past 6 o'clock now. I think I don't think we can entertain any more questions or comments. It only leaves for me to say that I must confess to being impressed by the presentations of all our three speakers. They speak of their experiences from different perspectives, traditional as well as academic, but all serving one common purpose, that is to enhance all matters related to presentation. They have given us all food for thought. Thank you very much, guys. With that, may I conclude by expressing our appreciation to all our speakers and participants. We would also like to record our appreciation to ISSUP Global for hosting this webinar, and of course to ISSUP Malaysia for organizing this webinar. It is our hope that this will not be the last webinar organized by ISSUP Malaysia. We look forward to many more. And with that, thank you. I would like to express thanks to all our speakers, as well as to Olivia for conducting this webinar. Thank you very much. Thank you all.
Thank you.
Thank you and have a nice day.
Thank you.
Thank you.
All right.
Thank you.
Thank you.
Good day.
Thank you.
Thank you.